Hello, everyone. Can everyone hear me? Hello, guys. If everyone can hear me and all is well, please just say in the chat. Okay, everybody. So, welcome to Mind the Bleep. My name is Dr. Zayd Noufal, and today I will be teaching you guys about emergency cardiology and the role of radiology. This is a teaching session, a part of our anatomy and diagnostic imaging masterclass, where we try to teach medical students, foundation doctors, and anyone really the role of radiology within kind of emergency presentations, emergency teaching. So this session will be mainly about cardiology and cardiac pathologies and how uh, radiology can help diagnose and sometimes treat such conditions. The way this will work is we will be going through cases, case by case by case. These are based on real MCQs, okay, stuff that will come up in exams, so it's very high yield stuff, okay? So we'll be going case by case, and I will start with presenting you a case. You will present me with what condition you think it is, what diagnosis you think it is, and possible management, and then we can go through how this is a radiological diagnosis and how this condition is treated. Okay, so let's go ahead with the first case. So, if everyone can see this slide now, case number one. A 31-year-old gentleman presents with chest pain that worsens when lying flat and improves when sitting forward. He had flu-like symptoms last week, and his troponin is mildly raised. And if you look below, this is what the ECG shows. I'll just move this for you. Okay. You can have a look at the ECG. All right. And I want you to tell me what your top differentials are, what investigations you want, and what you would expect to see on the imaging. Okay. So if everyone can just type in the chat, what are your top differentials for this case? 31-year-old, he's got chest pain. It's worse when he lies flat and improves when he sits forward. He had a recent infection / flu-like symptoms last week. You test his troponin, it's only very mildly raised. We can say his troponin is maybe between 20 and 30. No previous cardiac history, and you have a look at his ECG. If you look at the ECG, you can see there's widespread ST elevation in leads 1, 2, lead 3. There's some ST elevation. Even in leads AVR, AVL, AVF, there's some slight elevation, and V2 and V3. So almost even V5 and V6. So almost ST elevation in all leads. Okay. And yeah, so what investigations do you want for this patient? What investigation would you guys go for? Okay. You've tested his troponin, you've taken the bloods. Okay. And if you did any imaging, what would you expect to see? What what kind of imaging would be indicated in this patient? He's just come into A&E. What kind of imaging would you like to do? So we'd always like to start with a, so good. So Tahmid had the first, Tahmid there said query pericarditis. Yes, that's definitely one of our differentials. What kind of investigations would we like to do? I think I'll go for a bedside ultrasound. Okay, so if we go to the next slide and see. So, Tahmid, well done, you are right. So, of course, yes, we'd get a chest x-ray to rule out maybe a pneumothorax, maybe any signs of chest infection. Okay, as you can see here, the signs are all in keeping with the pericarditis. Okay, so on the bloods, he's had a raised CRP, raised ESR, sometimes a raised troponin. Okay, he had widespread ST elevation in all leads, and again, PR depression. So if you look here, you can see PR depression in leads 1, leads 2, and AVF as well. You can see the PR depression over there. Okay. Um, Again, the ST elevation is concave in shape. Okay. Oftentimes they will present with tachycardia and chest pain. So a key feature is chest pain that actually improves when the patient leans forward. Okay, that stops that pericardial rub, the pericardial rub, the pericardial friction. So when you lean forward, the chest pain tends to improve. Okay. Oftentimes they can also present with symptoms of infection. Okay, so the first thing you do, if available, you would do a bedside ultrasound or a bedside echo to assess for any signs of pericardial effusion, any signs of tamponade, and like Tahmid rightfully said, a chest X-ray, which is usually normal unless there's a large effusion, but most of the time you do a chest X-ray just to rule out any more sinister conditions. Okay. Um, Again, management is usually quite conservative unless the patient is really unwell. So you just give some NSAID, some ibuprofen, and some colchicine first line. You'd avoid steroids most of the time, unless the cause you think is autoimmune or it's recurring pericarditis. Okay. Again, you'd probably want to book this patient some follow up to monitor for any tamponade or monitor for any recurrence as well. Okay. Any questions so far? Okay. So in that case, we'll just move on. So this is what the CT would show in pericarditis. So although it's not first line, CT can prove very, very useful in assessing pericarditis. Okay. You can see here, this is actually a patient with some effusion in the CT. You can see there's some considerable amounts of fluid in the pericardial sac with some enhancements. So if you look around the heart, this kind of darker fluid on the right hand side, you can see it's this is all fluid within the pericardial sac. Okay. Some smooth thickening and enhancement of the surfaces. This is consistent with a infective or inflammatory cause of pericarditis. Okay. And if you look at the lung bases as well, you can see that there's some effusions also in keeping with some kind of infection. Okay. So you can see there's kind of blunting of the diaphragm. Okay. Some effusions there. Okay. It can also show if there's any calcifications and any thickening, and also evaluating if there's any sort of concomitant diseases that are occurring alongside or causing this pericarditis. Okay. So within, if you look above, you can see the in the middle picture, you can see this is the bedside ultrasound or echo. Okay. You can see where that yellow star is. That is actually some pericardial effusion. It's little darker than the normal kind of whiter picture of the myocardium. That's because there's no blood, there's no blood flow, hence it shows up as darker on the ultrasound. And the pleural effusion, where the red star is just there, that's some pleural effusion around the lungs. Okay, and that slightly darker circle there is the descending aorta. Okay, which looks normal. Again, if you look at the bottom right, you can see on the right hand side, that's the left ventricle, the right atrium, and the left atrium. And where that white arrow is pointing is some pericardial effusion as well. Okay. Okay. So moving on to the next slide now. This is the second question, second case. You have a 66-year-old gentleman with a history of tuberculosis. He presents with 3 weeks of fatigue, ankle swelling, and abdominal bloating. Okay. His JVP is raised with prominent X and Y descents, and there's a loud early diastolic knock uh, when you auscultate. Okay. So you're auscultating, you're trying to listen to his heart. Upon diastole, you hear a loud knock. Okay, the lungs are clear. What condition are you considering, and how would you confirm this diagnosis? Okay, please just comment in the chat what you think this might be, how you'd confirm it, what investigations you'd like to do, whether it may be bloods, any kind of imaging you'd like. If anyone in the chat can just let us know. Okay. Any thoughts? Okay. 66-year-old, previous history of TB, tuberculosis, and 3 weeks. He's had 3 weeks of fatigue, feeling extra tired, some ankle swelling, some abdominal bloating, and a raised JVP. Okay, so it sounds kind of like a heart failure type picture, but he's 66 years old, so he's still slightly quite fairly young. Okay, and this is only a 3 week history, so usually you'd expect heart failure to be a more of a longer term, long standing history. Okay, and also not in keeping with the bloating, abdominal bloating. So, if no thoughts in the chat, we can move on to the next slide. So, he's actually showing a signs of constrictive pericarditis. Okay, these lead to symptoms of right heart failure. Okay, um, this is quite a rare condition, but it is quite common in those who present with TB. This is when there's sort of calcification of the pericardium, and that kind of stops normal systole and diastole in the heart, so the heart can't fully expand and pump out. It mainly happens on the around the right ventricle and the right atrium. Okay, hence the heart can't contract properly, and therefore cannot push out enough blood from the right side hand side of the heart. This leads to signs of right heart failure. Okay, meaning there will be pleural effusion around the lungs. There would be fatigue. There will be peripheral edema, and there'd be ascites due to the backlog of blood upon the portal venous system as well. Okay, so again, other signs will be elevated JVP, pericardial knock, okay, upon early diastole, and Kussmaul's sign, which is JVP actually sometimes visibly increasing with inspiration. Okay, so usually JVP should decrease with inspiration. Okay, as the chest wall expands, blood can return to the heart. Okay, through the internal jugular, and the SVC blood returns to the heart when the chest expands. However, when with Cosmal sign, because there's so much pressure and strain on the right side of the heart, with inspiration, actually the backlog of blood causes the JVP to increase. Okay, so if you look at this CT here, which is the gold standard in diagnosing constrictive pericarditis, you can see there's some pericardial thickening. You can see there's some hyperattenuation of the pericardium here. There's some extra calcification here on the left hand side or the right side of the heart, the left side of the image. And you can see, if you look at the lung bases as well, there's some pleural effusion and some collapse in the bases as well, especially in the right lung, in the left side, left lung as well, right hand side of the picture. And if you look just there on the right hand side, the left lung, you can see them. There's a small line between the ribs and the heart. Okay, this is actually um, septal thickening between the lobes of the lungs. Okay, which is often a sign of pericarditis, constrictive pericarditis as well. Okay, management of this is usually just with diuretics, so you manage it as if you're managing heart failure in a way, but the definitive management would be a pericardiectomy, which is surgical removal of the pericardium. Okay. Any questions so far? Okay, good. We'll go to the next. Okay. So we have our third question now. Let me just get my camera back up. Okay. Yeah. Okay. Good. So we have our third question now. If you guys want to have a read, I'll also read it to you. We have a 24-year-old gentleman presenting with chest pain, palpitations, 1 week after he's had a bout of diarrhea and abdominal pain. Troponin is significantly raised, it's around 200. Okay. ECG is done and coronary angiogram is done. Okay. Following the ECG. So why would you do first? My first question would be, why would you do a coronary angiogram in a 24-year-old gentleman? Okay, no cardiac history, but he's presenting with chest pain and palpitations. Okay, so if you look here, he's had ST elevation in leads 1, leads 2, and V4, V5, and V6. Okay, so straight away you would suspect, okay, potentially despite his age, this young man is having a STEMI. Okay, he's having some sort of infarction. So straight away you'd get a coronary angiogram. However, having a look at the angiogram just here, you can see that it's largely pretty normal. There's not much evidence of any constriction in the vessels. It looks like a pretty normal angiogram. No signs of any STEMI or any sort of cardiac signs, really. So, what other differentials would you have in this case? 24-year-old who's just come in with some chest pain and some palpitations, significantly raised troponin, and he's recently had some sort of GI infection. What do you guys think this could be? Any ideas in the chat? So there's a little bit of a lag. So Okay, so moving on to the next slide. Okay, so this is actually a pretty rare case. This gentleman had a myocarditis, most likely from a infective cause. Okay, so the main symptoms of this would be chest pain, palpitations, dyspnea, shortness of breath. Again, they'd have tachycardia, and in very severe cases, they'd have a S3 gallop. If you had to listen to their heart, they'd have a S3 gallop. Okay. Again, ECG findings are usually non-specific. You'd have ST changes that are not really specific. So in an MI, you'd see leads 2, 3 AVF, can be like an inferior type of MI. Leads V4, V5, V6, and lead 1 could be some kind of like a lateral MI, etc. However, with the myocarditis, the ST changes are not very specific to a certain area of the heart. They're kind of generalized ST changes, um, which can be indicative of myocarditis. There's also, you can often see T wave inversions as well. Okay. Um, First thing you do, of course, blood tests. You see elevated troponins and elevated AFMs. And the gold standard is actually a cardiac MRI. Okay, so the late enhancement in the contrast gadolinium would be indicative of myocardial inflammation. Okay, um, again, you can do an endomyocardial biopsy, but this is really reserved for quite uncertain cases. Usually, a cardiac MRI is more than enough to diagnose this condition. And in the next slide, I'll actually be showing you some images of cardiac MRIs and how this can, in a way, be interpreted to help you make your final diagnosis. Okay. So again, most patients experience very mild symptoms. Main advice is to avoid any strenuous exercise. It oftentimes gets better by itself. Okay, and there's no need for management. Although sometimes standard heart failure meds can be beneficial. So bad meds, BAAD, beta blockers, ACE inhibitors, aldosterone antagonists such as spironolactone or eplerenone, and or diuretics such as furosemide can help provide some symptomatic relief. Okay. Oftentimes, it's also good to take some serial ECGs to monitor for recovery over time. Okay. So moving on, I'm going to show you some images now. So this is a cardiac MRI. It's quite a specialist examination. Um, and if you can see here, it can help show you many different cardiac conditions. So if you look here in image A is actually showing you a cardiac infarct. So this is a subendocardial infarct, oftentimes presenting with non-ST elevation. So this will be an N-STEMI. Okay. If you see here, there's some enhancement in image A in the sort of bottom middle of the picture. Okay. Image C is more in keeping with image C is more in keeping with myocarditis. Okay, if you can see here, there is some mid-wall hyperenhancement. Okay, mid-wall hyperenhancement is often in keeping with myocarditis rather than any kind of MI or anything like that. Okay, and again, image D as well. If you look at image D, you can see again some epicardial hyperenhancement, so around the heart, which can be in keeping with sarcoidosis um, and myocarditis as well. So if you see mid-wall hyperenhancement or epicardial hyperenhancement, it's oftentimes myocarditis. Now, oftentimes you won't actually have to interpret these cardiac MRIs as a junior doctor or a medical student or anything of the sort. Often these are very, very specialist examinations that are either interpreted by a cardiac radiologist or a cardiology specialist, really. So, but it's still very beneficial knowledge and things you can definitely use going forward. Okay. Now, on to our fourth case. This is oftentimes a very, very common exam question. Okay. You have a 70-year-old gentleman. He's got known AAA, which has increased in size from previously being 4.9 centimeters to now being uh, 5.6 centimeters in over 6 months. What is the most appropriate management for this patient? What do you guys think? A, B, C, or D? I'll just any thoughts? Just let us know in the chat. So it's actually quite a trick question. This question. Um, would you repeat the ultrasound in 6 months? Would you start a statin and monitor? Would you refer to the vascular surgeons or the cardiothoracic surgeons to consider repair? Or would you arrange an MRI angiogram? Good. So we've got someone here in the chat has said C. So well done, actually. If this lesion was actually, if this AAA was actually just zero point 0.1 centimeter less, this would have been the wrong answer. But because it's over 5.5 centimeters, the best management would actually be to refer to vascular surgery. Okay, these are very, very, very common topic in exams, and it's really this graph, this table here, is actually oftentimes widely asked about in MCQs. Okay, so anything under 3 centimeters, you just leave it. No further action is needed. Anything between 3 to 4.4, you will rescan in around 12 months. Okay, and anything between 4.5 and 5.4, okay, these are medium-sized aneurysms, you'd rescan in 3 months. Okay, but anything above the size of 5.5 centimeters has potential to kind of to burst, really, and you should probably be referred to vascular surgery um, as soon as for an elective, most likely intervention. Again, this is only found in one in sort of 1,000 screened patients. Okay, so I know in the UK there's a screening program which starts, I think, everyone above the age of 60, I believe, begins to be screened for AAAs. So anything that's seen, and then they are kind of appropriately referred to vascular surgeons or or cardiology to for appropriate management. Okay, so moving on. Any questions? Just drop them in the chat, please. Good. So signs and symptoms. Oftentimes, you will have a pulsatile abdominal mass, although this is oftentimes mainly for your OSCEs and for your exams. In reality, it's really, really, really difficult to pulsate or to detect unless it's a really massive aneurysm. It's really difficult to detect the pulsatile mass in the abdomen. Okay, but what is common is they will have abdominal pain, often radiating to the back, and sometimes even flank pain, which is dull and non-specific. Okay, oftentimes if it's a big aneurysm as well, they can have early satiety, so they'll get full really quickly. And if you auscultate over the aorta, you will often hear some bruise. Okay, bruise will sound like a kind of a whooshing noise. Okay, which you can hear upon auscultation of the abdomen. So first thing you do if you suspect AAA, you auscultate, you have a feel, you examine, and you take a good history, okay, to try and determine what the cause may be. Okay. Now, a ruptured AAA, on the other hand, is actually a high mortality surgical emergency, and they usually will be very unwell patients, hypotensive, oftentimes unconscious. These will oftentimes have a pulsatile abdominal mass, and they will have presented with severe abdominal pain, a ripping kind of pain, ripping sensation that they describe, that radiates to the back. Okay. Sometimes it can also radiate to the flank or to the groin. Okay. They may even have signs of internal bleeding, such as Gray Turner sign, which is bruising of the flanks, Cullen sign, periumbilical bruising, tachycardia, shock, altered mental status, all signs of being really unwell. Okay. Oftentimes they may even have limb ischemia, especially if has been some distal emboli kind of thrown off. Okay. So these are often these patients with ruptured AAAs are usually very, very, very unwell. In contrast with with those who are unruptured, they can usually go undetected for a long, long time, which is what makes this condition actually so dangerous. Okay. So moving on. Okay, so the gold standard diagnosis for AAAs is actually a CT angiogram. So you suspect AAA in one of your patients. The first thing you'd want to do is a CT angiogram. Okay, um, unless it's ruptured. If it's ruptured and they are unstable, you stabilize them, and then you can take them to CT to confirm your diagnosis and treat appropriately. Okay, so after initial bedside ultrasound, if available, you do a bedside ultrasound. Then, to make a formal diagnosis and or to plan a surgery, you would actually go ahead with your CT. Okay, so my face is probably covering the first CT very slightly. However, if you look at the image on the left, this is actually an image of a ruptured AAA. Okay, so if you can see, the borders are quite irregular, and you can see that there's some clear kind of blood, sort of blood loss from the aorta itself. Okay, so rather than it being a nice round in shape, you can see that there's some extravasation of blood, really, just leaving the aorta just there. Okay. In contrast to the image on the right, where it's an unruptured AAA. So the unruptured one, you can see here is nice and symmetrical, circular in shape. Okay, and there's some hyperattenuation, but it's not ruptured. Okay. Now, the treatment for AAAs is oftentimes actually a radiological treatment. So EVAR procedures are either done by cardiologists, but can also be done by interventional radiologists, um, and sometimes by vascular surgeons as well. So the way these work are, you insert a catheter into one of the leg arteries. Okay, you locate the location of the aneurysm, most likely using some contrast, and then using this catheter, using your guide wire, you slowly release the stent. This this heparinized stent is pushes the walls of the artery, okay, expanding the walls of the artery and reinforcing the aortic walls to stop any rupture and to stop, you know, and to remove any kind of move any plaques or clots to the side and ensure normal blood flow. Okay, these are usually very successful, very safe procedures, and they're very good treatment for AAAs. Okay, moving on to the next case now. Before that, if there's anyone who had any questions, please just drop them in the chat. Okay, moving on to the next case. You have a 58-year-old woman. She presents with sudden onset severe chest pain radiating to her back. Her blood pressure is high at 190/100 in her right arm. However, in her left arm, it's only 140/90. Okay. Her left radial pulse is reduced, and you do an ECG, but it's largely normal and doesn't show any ischemic changes. What does everyone think this could be, and what investigations would you like to do? Just drop in the chat, please, if anyone has any ideas. Okay, I'll give you a few more seconds in the chat, and then we can move on. Good job, Suleiman. Well done. So moving on. So Suleiman rightfully said aortic dissection. Well done. So if for those who know, aortic dissection is can present as a sudden tearing chest pain or back pain, and the kind of the key symptom is the differing blood pressure between the right side and the left side of the body. Okay, they can also show with signs of stroke, signs of tamponade, and limb ischemia as well. Okay, why does this happen? So if you know, aortic dissection is when there's actually a hole or kind of a perforation in the wall of the aorta, and so blood flows in the lumen of the artery rather than the artery itself. So the aorta dissects, the lumen oftentimes expands to become much larger than the actual passage of blood. Okay, and this can be quite dangerous. Okay, why does it cause a difference in the blood pressure? Because especially if there's a dissection in the ascending aorta, this can kind of occlude the subclavian and the brachiocephalic arteries, which can narrow these major arteries and reduce blood pressure to that limb. Okay, so oftentimes a person presents with back pain, chest pain. You'd measure their blood pressure, but oftentimes what's missed is you don't measure their blood pressure in both arms. So you should always measure blood pressure in both arms if you're suspecting aortic dissection. Okay, moving on. So if you can see here, what I was explaining earlier, there's a tear, so lead to blood to move into a false lumen. If you look at that picture in the middle, blood will move into the false lumen, expanding the false lumen, and the true lumen actually gets smaller. And if you can see, the brachiocephalic artery coming off the ascending aorta can lose blood flow as a result of this, resulting in differences in blood pressure. Okay, mainly in the right limb will have the lower blood pressure compared to the left limb. And if you look at the CT angiogram, which again is the first line gold standard to diagnose aortic dissection, you can see here that that small black line where the arrow is pointing is the kind of the entry point of the false lumen. See that the true lumen has become very small and the false lumen has increased quite drastically in size. Okay, moving on. Any questions, just please let me know. Again, now a type B aortic dissection. They're oftentimes quite hard to diagnose, but these will be in the descending aorta rather than the ascending aorta. Okay, and if you can see here, they're quite clearly visualized on the CT, especially in the sagittal view. You can see that there's quite clearly two lumens. Okay, and CT angiogram again is the key golden diagnosis for this condition. Okay, next. So again, aortic dissections are classified in three different ways. There's the Stanford criteria and the DeBakey criteria. So they both kind of work together. So Stanford defines them in type A and type B, and then DeBakey will class them in type 1, 2, or 3. On the left is a normal aorta. You can see that you've got the abdominal aorta, descending aorta, aortic arch, and the ascending aorta there. Okay. Type 1 involves the ascending and the descending aorta. Okay. This also falls under type A. Type 2 involves only the ascending aorta. Okay. Whereas type 3, aka type B, involves only the descending aorta distal to the origin of the left subclavian artery. Okay, so anything distal to the left subclavian is type B. Anything proximal to the left subclavian is type A in Stanford. Okay, and then they can be broken down into types 1, 2, and 3. Anything that's type A, meaning it's proximal to the left subclavian, should be managed surgically on an emergency basis and to control blood pressure with fluids and or blood transfusions if needed. Type B can oftentimes be managed conservatively using blood pressure reduction. Oftentimes can give IV labetalol if it's an emergency, and you prevent progression by keeping blood pressure well controlled. Okay, and that is all. Thank you very much, everyone, for joining. If you can please drop your feedback, it would be much appreciated. Okay, hope you guys enjoyed the session. If there's any questions, please just drop them in the chat.